First of all, I have to thank the IPDI, Dr. Mohsin, Dr. Wadood for calling me here. And today I'm going to speak on what's new in the lipid lowering therapy. And I would say there are three new things. Number one is some new drugs have come, so we need to look at that. Number two is that targets have been set and different target at different levels. So we will just talk about that. And the third thing is that an algorithm has been set up in different groups of how to treat those specific patients. So time is short, but I'll try to cover all of them. Let us see if it's possible or not. So I think what is important to know is that whatever information we have is complete, is accurate and honest. And we have to look at, of course, at what, why, when and how, and I will just try to do that. So before going into the depths, let us look at what is unique in this particular field of lipid lowering. So number one is that there is no single pathway. So lipid metabolism is complex, and since there is no single pathway, it is possible that single drug may not work, and we may need more than one drug. Other important thing is that dyslipidemia is associated with significant morbidity and mortality. But the good part is that this is one disease where if you can bring down dyslipidemia, then you can improve morbidity and mortality both. The another interesting thing is that among all, LDL is the most important factor, and therefore need to focus on that. As I said, that targets have been set up. Previous guidelines were not talking of targets, but newer ones are indeed talking about it. And different populations are at different risk of having the events, and therefore the targets may be different. And therefore, the intensity of treatment may vary in different patients. Also, the time frame that is available for action is also different in different patients. And of course, all of us know that there is huge discrepancy in cost of the drugs that we use here. Now, before we go any further, we need to look at the mechanism of action of different drugs. Basically, broadly, there are two types of drugs. One, which are decreasing the formation of cholesterol. They may act through HMG-CoA, like statins, or they may act via bempedoic acid, which acts at multiple levels. Both of them, what they are doing is that they are bringing down the cholesterol levels. While statins have many other actions also, besides action on liver. So they may have actions on muscle, they may have action on brain and all over the body, and therefore a lot of side effects. Bempedoic acid has action only on liver. So that is why some side effects may be lower with this particular drug. But effectivity of bempedoic acid is lower than statin. So this is one thing. The other mechanism is, as I said, increasing the LDL receptors. And now many drugs are available, the PCSK9 inhibitors and all, which actually increase the level of LDL receptors, and through it they act. The third group of drugs are ones which act on the carrier protein and therefore decrease the carriage of cholesterol that is formed in liver, and this is the third group of drugs. So we will quickly touch them one by one. Time is very short, but as you know that LDL shows a linear relation with atherosclerosis and events. This is well known. These are the goals I was talking about. And basically what it has now said that if you are at a very high risk category, then you need to bring LDL cholesterol less than 55. If it is a high risk group, maybe with a coronary event sometimes, then you may need to bring it less than 70. In a moderate risk group, which may be associated with many risk factors, just dyslipidemia, no CAD, you may want to bring it less than 100. But with no risk factors, still it is a good idea to bring it less than 115. So these are the targets for everybody, and depending on which risk category you belong, if you have had repeated episodes of PCI, cabbage, etc., then you are a very high risk group. And even if there is another super high risk group where you have recurrent events even after controlling the cholesterol, where you might need to bring it down less than 40. So these were one thing that I wanted to tell you. And this is exactly that, different groups and having different targets. So I will not go into detail because time is short. The other question I talked about is how early you should start treatment. And most of the studies have shown the earlier you start, the action of statins, for example, can start as early as 1 month and can prolong to a long duration, maybe more than 5 years, 10 years even. So you have to start immediately and keep going for long term. And likewise for other drugs also, the similar early effect and long benefit exists. Even in post-PCI patients, in acute coronary syndrome patients, the same thing is quite observable. Now, we of course know that statins are drug of choice in most of the lipid-lowering therapies, but there are a lot of many other drugs available acting by different mechanisms: fibrates, niacin, bile acid sequestrant, probucol, and omega fatty acids. Practically all of them decrease LDL cholesterol. Some of them may also decrease triglyceride and increase HDL. The problem with these drugs is that while statin is very strongly related to reduction in morbidity and mortality even, these drugs have not shown that benefit. So they might have very little effect on the coronary events and basically no effect on mortality. That is why we need to choose statins, because they have such a good effect on mortality, unlike these other drugs. So as you can see that there is a mortality benefit with statin that is present over a period of time. You can see even 25 years, the benefit keeps on piling up. But there are, of course, all of you know certain issues with statins. They lead to mortality reduction, but only 30%. So 70% mortality is still persisting, number one. Number two, they are not effective in all the cases. So as I said, only some people they are effective. Then the other thing is that there could be side effects related to statin, because as I said, they have action all over the body. So some side effects can happen with statins. And last but not the least, they have no impact on triglyceride, and maybe rosuvastatin little bit increases HDL. Others have no effect on HDL. So these are the problems with the statins. And that is why we look at this residual risk with the statin, and we need to fix it. Now, if you look at some of the already existing drugs that are available, you can see that they can help reducing those problems. But again, as I said, they have very little impact on the event rates or morbidity, and practically no impact on mortality. So basically, they are just time pass drugs. They are not really, benefiting the patient in a big way. STPP is a good example, but again, same thing. It decreases the LDL cholesterol, but have no effect on outcomes and no decrease in mortality. So this is the thing. Then coming to the new group of drugs, which are acting on the LDL receptors, and how they act on LDL receptors. If you look at the cartoon, what happens is, once the receptor binds LDL, it brings to the cytoplasm, and then it disintegrates. The cholesterol gets digested while receptor moves to the surface again to capture more cholesterol molecules. But when this PCSK9 actually, when it binds to the receptor, what it does is it prevents the destruction of it actually causes the destruction of the whole LDL molecule, receptor molecule also. So less number of LDLs are available. So if you can block PCSK9, you can increase the number of receptors. So there are monoclonal antibodies against PCSK9, evolocumab. You can see a very good reduction up to 60%, even more than what statins do, even on the top of statins, still further 60% reduction. Not only reduction, it also decreases the event rate, MACE, and has even some effect on mortality reduction. So this is another drug other than statins, which can also in a big way impact the event rates and even mortality. Both the monoclonal antibodies, evolocumab and the other one, both of them actually reduce this thing. So this is the evolocumab after MI, and you can see a good reduction in the event rates. And basically, after PCI, again, you can see benefit is there. Now, monoclonal antibodies, these evolocumab and other things. But there is another mechanism by which we can block the PCSK9 molecule, and one is this nonsense mRNA, which is produced by inclisiran. This is a new drug which can produce this nonsense mRNA, and it can block the actions. And you can see that benefits persist long term. And I think I'm running out of time, so it will go away. So just wanted to show you this drug that the thing is that it can reduce the risk, or it can bring down the LDL cholesterol, but so far no benefit in terms of morbidity or mortality or event rate has been shown so far. There are trials going on, and so we may see later on. So it can be used, especially in those cases where on the top of, it's still coming? Okay. On the top of other drugs, you can add it and you can have an additive effect. Acid, I already, okay, it has come back. So this one shows that there is a marked reduction in the LDL cholesterol on the top of all the ongoing therapies. So I will just quickly go and I will show you the main thing. Bempedoic acid, I already told you, because it does not act beyond liver, so it is useful in statin intolerant patients. So this is one. And low, I already told you, so I will not waste time there. Then some other drugs I said were lomatapide and evanocumab, which is another monoclonal antibody against angiotensin-like molecule. So these are two other drugs useful in familial hypercholesterolemia because they act by different pathways. And I will just come to this. So this is, if statin is unable to achieve target, you add estimib. If it is still not working, you add PCSK9 monoclonal antibodies. If not effective, then you can add inclisiran. If nothing works, you go to plasmapheresis. If a patient is intolerant to statin, then naturally no point in giving statin. You give estimib. Then if it is not working, then bempedoic acid. If not, then plasmapheresis. And finally, in a patient of familial hypercholesterolemia, if statin is not working, estimib, PCSK9 inhibitor, bempedoic acid, and then these evanocumab and lopepidide, and then finally plasmapheresis. So thank you so much for your time.
Thank you. Thank you, Dr.